A man doubles over in agony, unable to urinate. The pain has been building for weeks, sharp and constant, centered deep in his pelvis. A stone has formed in his bladder, blocking the passage of urine and growing larger daily. Without removal, the stone will kill him through infection, rupture, or simple urinary retention. With removal, he faces the most painful surgery medieval medicine could offer. No anesthesia exists. He will be fully conscious while a surgeon cuts into his perineum, the area between his genitals and anus, reaches into his bladder with metal instruments, and extracts the stone. The procedure takes minutes but feels like hours. Many patients die from shock during the operation. Others survive the surgery but die from infection days later. Yet some live, freed from their torment. How did medieval people endure bladder stone removal, and what made this particular surgery so uniquely horrifying? Before we uncover the brutal techniques and desperate measures that defined lithotomy surgery, if you're fascinated by how medieval medicine pushed human pain tolerance to its absolute limits, subscribe now. The most agonizing part is still ahead. Bladder stones formed when minerals in urine crystallized and accumulated over time. Diet, dehydration, and chronic infections all contributed to stone formation. Medieval diets, often lacking in variety and heavy in certain grains, created conditions favorable for stones. Once a stone began forming, it could grow surprisingly large, sometimes reaching the size of a hen's egg or larger. The symptoms were unmistakable and progressively worse. Initial pain during urination escalated to constant pelvic agony. Blood appeared in urine. The urge to urinate was constant, but produced little or no flow. As the blockage became complete, urine backed up into the kidneys, causing fever, nausea, and delirium. Without intervention, kidney failure or bladder rupture would follow, both fatal. Medieval people understood that something solid was blocking urine flow, even if they didn't understand the chemical process creating stones. Physicians could sometimes feel large stones by pressing on the lower abdomen or performing internal examination. Once diagnosed, the patient faced a terrible decision: live with increasing agony until death, or undergo lithotomy surgery. Lithotomy, meaning stone cutting, was one of the oldest surgical procedures known to humanity. Ancient civilizations performed it, and the techniques passed through centuries with refinements but no fundamental changes. The surgery remained essentially the same throughout the medieval period, because the anatomy didn't change, and the tools available were limited. The procedure was so specialized and dangerous that most regular physicians refused to perform it. Instead, traveling stonecutters, specialists who moved from town to town offering their services, dominated this field. These practitioners were often not formally trained physicians, but experienced surgeons who had learned the technique through apprenticeship and repetition. Stonecutters advertised their services in town squares, sometimes displaying stones they had successfully removed as proof of their skill. Their reputation determined their success. A stonecutter known for high survival rates could charge premium prices and attract patients from wide regions. One known for killing patients would be driven from towns or worse. The patient preparation began with positioning. The standard position for lithotomy was lithotomy position, which gave the procedure its name. The patient lay on their back on a sturdy table, knees drawn up toward the chest and legs spread wide. This exposed the perineum, the surgical site. The position was maintained by assistants or by tying the patient's legs to supports. Restraint was essential. The pain would cause violent thrashing, and any movement during the critical cutting and extraction could cause fatal injury. Strong men, usually 4 to 6, held the patient down. Arms were pinned to the sides. Legs were held firmly despite their bound position. The chest was pressed to prevent the patient from sitting up. A leather strap or wooden rod was placed in the patient's mouth to prevent tongue biting and muffle screams. Some stonecutters used specialized tables with built-in restraints. Leather straps secured ankles, wrists, and torso. These tables were more effective than human holders, but more expensive and less portable. Most traveling stonecutters relied on available furniture and strong assistants recruited locally. Before cutting, the surgeon needed to locate the stone precisely. He inserted a finger into the rectum, feeling through the rectal wall for the stone in the adjacent bladder. This examination was painful but necessary. The surgeon needed to know the stone's size, position, and shape to plan his approach. A large stone required a bigger incision. A stone near the bladder neck was easier to reach than one positioned higher. Some surgeons used a grooved metal staff called a gorget, inserted through the urethra into the bladder. The groove in this instrument would guide the cutting knife and help locate the stone. The insertion of this device was itself agonizing, forcing metal through the sensitive urethra into the inflamed bladder. The cutting began with the patient fully conscious and aware. The surgeon made an incision in the perineum, cutting through skin and muscle layers to reach the bladder. The standard approach was lateral lithotomy, cutting to one side of the midline to avoid major blood vessels and the urethra. The surgeon cut carefully but quickly, knowing that speed meant less blood loss and less time for the patient to remain in shock. Blood welled from the incision immediately. Assistants used cloths to mop it away, trying to keep the field visible. The surgeon's fingers probed the wound, feeling for the bladder wall. Once located, he cut into the bladder itself, creating an opening large enough to admit instruments. The pain was beyond description. Medieval accounts describe patients screaming until their voices gave out, then making choking sounds or going silent in semi-consciousness. Some lost control of their bowels, others thrashed so violently that even multiple holders struggled to keep them still. The surgeon worked through this chaos, focused on the anatomy before him. Once the bladder was opened, the surgeon inserted forceps or his fingers to grasp the stone. This was the most delicate moment. The stone had to be extracted through the incision without tearing the bladder further or lodging in the narrow opening. Small stones could be pulled out easily. Large stones required manipulation, tilting and rotating to work them through the opening. If the stone was too large, the surgeon might have to break it inside the bladder using special tools. This fragmentation was risky, as sharp stone pieces could lacerate the bladder wall. But it was sometimes the only option. The surgeon would crush the stone with forceps or a lithotrite, then extract the pieces individually. The extraction itself caused different pain than the cutting. Patients described it as intense pressure, a sensation of being torn from inside. When the stone finally emerged, covered in blood and tissue, some patients fainted from relief mixed with continued shock. Others remained conscious, watching as the surgeon held up the cause of their suffering. Closing the wound was simpler than the extraction but still dangerous. Some surgeons stitched the bladder and perineal incision closed. Others left the bladder wound open to drain, arguing that closure trapped infectious material. There was no consensus on best practice. Both approaches had similar mortality rates, suggesting that postoperative infection was the real killer regardless of closure technique. Urine would leak through the wound for days or weeks after surgery. This was expected and unavoidable. The patient lay on absorbent materials that were changed frequently. The constant urine flow irritated the wound, preventing normal healing and creating ideal conditions for infection. Postoperative care was minimal by modern standards. The wound was kept as clean as possible using wine or vinegar. Herbal poultices might be applied. The patient was urged to drink liquids to flush the bladder, though this increased urine leakage through the wound. Pain management consisted of wine, ale, or opiate preparations like poppy juice if available and affordable. The recovery period was brutal. Fever almost always appeared within a few days, indicating infection. The wound became inflamed, swollen, and increasingly painful. Pus drained along with urine. The patient weakened, unable to eat, often delirious. Many died during this phase, between 3 days and 2 weeks post-surgery. Those who survived the infection phase faced a long healing process. The external wound would close gradually over weeks. The bladder healed more slowly, and some patients had permanent fistulas, abnormal passages that allowed urine to leak constantly. Others developed strictures, scarring that narrowed the urethra and caused ongoing urinary problems. The mortality rate for lithotomy was terrifyingly high. Estimates from various historical sources suggest that between 30 and 50% of patients died, either during the surgery from shock and blood loss or afterward from infection. This meant that choosing surgery was essentially a coin flip between death and survival. Stonecutters with better-than-average survival rates were highly valued. Some claimed success rates as high as 70 or 80%. Though these numbers are difficult to verify, skill mattered tremendously. A surgeon who cut precisely, worked quickly, and understood bladder anatomy saved more patients. One who cut clumsily, worked slowly, or made anatomical errors killed most of his patients. The psychological trauma of lithotomy was immense for those who survived. They had endured conscious surgery involving genital area cutting, prolonged agony, and witnessed their own stone removal. Many survivors described the experience as worse than any battle wound or accident. Some refused to discuss it, others became obsessed with it, repeatedly telling their story to anyone who would listen. Children underwent lithotomy as well, as bladder stones affected all ages. Pediatric lithotomy was particularly heartbreaking. The child couldn't understand why they were being restrained and hurt. Parents had to authorize the surgery, knowing the high death rate. Small bodies handled blood loss and shock more poorly than adults. Yet some children survived, freed from pain that had dominated their short lives. Women could develop bladder stones but underwent lithotomy far less frequently than men. Female anatomy made the procedure technically different and somewhat more complex. Some stonecutters refused to operate on women, citing the anatomical differences and higher risk. Women with bladder stones often suffered longer before finding a surgeon willing to attempt removal. The cost of lithotomy varied by region and surgeon reputation. Successful stonecutters charged substantial fees, sometimes equal to months of a craftsman's wages. This put the surgery out of reach for poor people with bladder stones. They suffered until death, unable to afford the surgery that might have saved them. Wealthier patients could pay for the best surgeons, better post-operative care, and expensive pain medications. Some charitable institutions, particularly monasteries with medical traditions, offered lithotomy to poor patients at reduced cost or free. These institutional surgeons performed the procedure as Christian charity, accepting the risk that patients might die under their care. The monastic setting offered some advantages: cleaner conditions, better nursing care, and access to herbal medicines from monastery gardens. The tools used in lithotomy were specialized and carefully maintained. The primary knife had to be extremely sharp for clean cutting. The forceps needed to be strong enough to grip stones firmly, but shaped to fit through the narrow bladder opening. Some stonecutters designed custom tools based on their experience, creating instruments that made their technique more effective. These tools were expensive and required regular maintenance. A lithotomy knife dulled from use had to be resharpened perfectly. Forceps that bent or broke during a difficult extraction had to be repaired or replaced. Stonecutters invested significant money in their toolkits, knowing that tool quality directly affected surgical success. Failed lithotomies were common enough that they entered popular culture. Songs, stories, and jokes referenced the stonecutter's knife and the screams of his patients. Some of this was dark humor, a way of processing the horror of a procedure everyone feared. Some was genuine criticism of surgeons who performed lithotomy carelessly or on patients too weak to survive. Legal protections for surgeons varied. Some regions had laws limiting liability for surgical deaths, recognizing that even skilled surgeons couldn't save every patient. Others held surgeons accountable, allowing families to sue or bring criminal charges if a patient died during lithotomy. This legal uncertainty discouraged some capable surgeons from performing the procedure, leaving the field to specialists willing to accept the risk. The social status of stonecutters reflected the procedure's nature. They were necessary but not quite respectable. Performing lithotomy regularly made them wealthy, but didn't earn them full acceptance in medical communities. They occupied a liminal space between respected physicians and lower-status barber surgeons, defined by their specialized skill in one terrifying operation. Advances in lithotomy technique occurred slowly. Individual surgeons refined their approaches, cutting at different angles, using different tools, or varying their closure methods. But without understanding of infection or anesthesia, fundamental improvement was impossible. The surgery remained essentially the same brutal procedure from ancient times through the end of the medieval period. How did medieval people remove bladder stones without dying from pain? They didn't avoid death reliably. Half died on the table, or days later from infection. The survivors endured conscious perineal cutting, bladder opening, and stone extraction with only leather restraints and strong hands holding them down. They screamed until they couldn't, thrashed until exhaustion overcame them, and experienced pain so severe that some later said they wished they had died during surgery. Stonecutters worked quickly, cutting deep into the most sensitive areas, extracting stones while patients watched, and hoped their skill and their patient's constitution were enough for survival. No anesthesia dulled the agony, no antibiotics stopped the infection. Some lived because they were strong, lucky, and treated by skilled surgeons. Others died in pain on the table or fever-racked in their beds days later. The stones were removed, held up as trophies, and patients either recovered or didn't. Medieval lithotomy was survival by ordeal, cure through torture, life purchased with suffering that pushed human endurance to its breaking point. If you enjoy the hidden sides of medieval life, hit subscribe and give this video a like.